But it is such a pleasure to be with you all today and to be with our three guest speakers to talk about first responder health and well-being. So first, we'll be hearing from Dr. Crowley Sear, and then who is an associate professor at the University of Southern Queensland, Australia. We'll hear from Sola, who's a commissioner of police in Nigeria Police Force. And finally, Mario Morales from the University of Arizona. So I'll let each of our speakers, present themselves, share a little bit about themselves before jumping into their presentations. And following the three presentations, we'll have some time for Q&A. And my name, sorry, didn't introduce myself. My name is Katie Bialik. I'm from the United States. I'm based out of Washington, D.C., and I work for philanthropy that works right at the intersection of law enforcement and behavioral health reform. So such a pleasure to be with all of you. Excited for today's presentation. Dr. Linda Crowley-Sear, would you like to go first?
Sure.
And I'll hand things over to you.
Okay, thank you.
Wonderful.
Good morning, everyone. Oh, sorry, good afternoon, everybody. My name is, it's a little bit early here in Australia, is Dr. Linda Crowley-Sear, and I'm a law academic. I'm actually a lawyer, so I'm a little bit odd in this conference. But today I'm going to speak about whether some plans in Australia, and I'm just going to share this screen, sorry. Wait a minute. Oh, that's the wrong one, obviously. What's going on here? Sorry. Share screen. Here we go. Can you see that? Can anyone see this presentation?
It's in presenter view.
Is that right now?
Yep, it looks great.
Oh, okay, thank you. So anyway, sorry about that technical. It's on presumptive laws, presumption laws, and we're looking at bringing some in the state of Queensland where I live, and I'd like to speak about that. So by way of overview, I'm just going to present a definition for those of you who don't know what presumption laws are, the objectives of the law. The context will be in Australia, but it's applicable to any jurisdiction around the world that has presumption laws. I'm going to specifically look at Queensland, where I live, which is one of the states of Australia, and I'm going to present some suggestions for possibly the way ahead. And I'm going to look at the Canadian approach because they're the world leaders in presumption laws at the moment. So what are they? Essentially, there are laws that create an automatic presumption that work trauma is the cause of a worker's post-traumatic stress disorder. To prove otherwise falls then onto the employer. The objective of these laws is to improve the workers' compensation experience and the mental health outcomes for first responders diagnosed with PTSD. And of course, that includes the police. So let's turn now to, oh, sorry, it's jumped. Let's turn now to a little snapshot of the Australian context in predominantly the last 3 years. So for police as individuals and as workers, as for other first responders, the events of 2019 to 21 have been particularly challenging. We've witnessed first responders, including police and army personnel, merge with other frontline workers and volunteers to defend us against some of the worst public health and safety threats of modern times. Now, in Australia, like elsewhere, these threats have been relentless. They've required police to engage in highly stressful roles in extremely dangerous circumstances for extended periods. In Queensland, this period is marked with destructive floods, followed by extensive drought, which hit our rural communities and rural police the hardest. Now, we're in the moment of floods right now. Who could have predicted that? No one. It's the worst flood in our area for over 100 years now. Then in the summer of 2019 to 2020 came what is known as Australia's Black Summer, which most people would be aware of. It was highly published in the news. There were 24 million hectares of land burnt, 3,000 homes were destroyed, and over 3 billion animals were killed or displaced, and that's not to take into context the fauna and flora. The fires claimed 33 lives, including 6 Australian firefighters and 3 our fellow Americans who came to our rescue, that were killed when their aircraft carrying a load of fire retardant collided with terrain. Now, the size of these fires is unprecedented. Police had the unenvious job of identifying the remains of all those who perished in any one of these events and reporting to the families. In carrying out their work, police have witnessed and rescued desperate people and animals. They breathed in toxic smoke as they managed large-scale evacuations, roadblocks, and rescues. And as the fires came under control, the pressures on mental health and well-being of police and first responders escalated yet again in January 2020. So it was relentless, with Australia identifying the first COVID-19 confirmed case. In Australia, containment measures for COVID to prevent community transmission included really strong border restrictions, lockdowns, and quarantining. And this led to endless new directives for police to contain the spread of the virus, such as managing quarantine services for returning travelers at hotels and health services. And we had a dramatic, scandalous cruise ship episode, the Ruby Princess, and controlling anti-lockdown protests, checking home detention compliance, and so on, all in the midst of an uncertain, invisible, and deadly virus. And they themselves could transmit this virus to their families. No one knew anything about it if they were exposed. Meanwhile, government expectations are such that first responders will be ready and able to protect the public from existing and emerging safety threats and rescue those at risk or deal with tragic fallout. And there's a commensurate expectation that first responder workplaces will ensure the safety of their employees from workplace injuries so that they can continue to carry out their work safely and with integrity. Now, this includes keeping them in top physical and mental condition in light of their exposure to tragic and traumatic incidents as and when they emerge. Now, in 2018 to 2019, the findings of 2 independent national reports on mental health of police and other first responders provided the evidence needed for change to the workers' compensation laws in Australia. Now, both echoed similar findings of 2 to 3 times higher rates. And I've heard this by other presenters at this conference. It seems to be a global thing, these reports that show double the rates of mental health problems experienced by police and other first responders than the general population. Now, both reports recommended early intervention and mental health support for all workers. This was based on findings that several barriers interfere with workers' compensation claims by first responders, and it included the usual suspects, the departmental stressors, such as stigma associated with mental health problems, workplace cultures within the organization that tolerate bullying and harassment of those who make mental injury claims, the poor return to work opportunities. And my focus today is on having to prove the mental injury that was suffered was caused by a specific traumatic incident in order to support the workers' compensation claim. On this last point, both reports suggested presumptive laws that recognize the cumulative effect of incidents that expose workers to trauma would make the process less stressful for first responders that are already suffering from PTSD. Now, perhaps more than ever, the evidence is clear, and the public has become aware that our frontline workers risk their lives to save ours. Police have joined public health personnel as part of a collaborative frontline protection strategy against many of the worst public health and safety threats. And it's imperative that they get the mental health and wellbeing support that they need as and when they need it. Now, in recent years, Queensland and other Australian jurisdictions have been active in workplace reforms, which is great, aimed at building public confidence that workers' health and safety is taken seriously. Most recently, following the footsteps of Tasmania and the Northern Territory, Queensland released its new Amendment Bill 2020, aimed at introducing presumption laws. And this is laudable. However, it raises the opportunity to consider whether the boundaries of the proposed laws could be possibly stretched to better meet the predicted needs arising from new challenges as those that I've touched on in this presentation. So my submission to Parliament identified two specific provisions in the bill that might better meet the objectives of the proposed changes. These are expand the presumptive coverage to include all work-related psychological injuries and expand the role of diagnoses beyond psychiatrists to include, other appropriately trained healthcare professionals. And I'm just going to look at those a little more closely. Now, the Queensland Bill draws a distinction between PTSD and other psychological injuries, which they argue are covered by general workers' compensation provisions. Now, these provisions are limited to financial support. So you get a number of visits to a psychologist paid for by the workers' compensation scheme, so you can get psychological services. Now, limiting the benefits of presumption laws to PTSD seems unnecessarily restrictive. PTSD trauma, as defined by the DSM-5, must be associated with death, serious injury, or sexual violence. Now, the limitations misses so many psychological injuries caused by traumatic events that are not associated with these. Stress, anxiety, and depression, they're symptoms of PTSD, can arise from other workplace stresses and risk resulting in what is known as burnout, for example. Now, burnout, it's a syndrome that shares similar symptoms to PTSD, but does not yet appear in the DSM-5. In May 2019, the World Health Organization described burnout as, quote, an occupational phenomenon resulting from chronic workplace stress that's not been successfully managed. Burnout is endemic in medical professions, law enforcement, and fire and rescue services. Research studies by the Black Dog Institute, which is the only medical research institute in Australia to investigate mental health of all ages, so they claim on their website, have found that associated symptoms can include emotional exhaustion or fragility, cynicism, sleep disturbance, brain fog, anger, depression, and yes, anxiety and stress. Now, these symptoms, if sufficiently severe, can affect good judgment and decision-making, which in certain conditions can put the health and safety of first responders, their colleagues, family, and the public they serve at risk, just like PTSD. The financial impact of burnout can be significant in terms of lost productivity and stress or sickness-related absenteeism, costing Australia, at least, an estimated $14.81 billion a year. Now, first responders as frontline services have repeatedly been found by national and international surveys, studies, reports. We've got plenty of evidence to carry high levels of stress that can increase the chances of mental health conditions developing and suicide risks if undetected and untreated. The ordinary compensation claim pathway, while it's available for other psychological injuries, is precisely what's been criticized for potentially re-traumatizing some first responders seeking workers' compensation. Arguably, the limitations to PTSD means the presumption laws are missing the opportunity to progress towards a compensation system that aims to avoid re-traumatizing all first responder claimants who are in need of work cover benefits. The limitation may be a barrier to any intended encouragement of first responders to come forward and lodge claims when they feel they may need it. I propose that the limitation to PTSD is outdated. As stated in the bill's explanatory notes, in 3 of Canada's jurisdictions, the presumption provisions introduced more recently and arguably based on improved knowledge and understanding apply to first responders with psychological injuries beyond PTSD. Canada has shown that broader definitions don't necessarily result in an opening of the floodgate of litigation or claims in those jurisdictions. Now, in terms of the limitation of diagnosis by psychiatrists, well, the new bill requires that a psychiatrist makes the diagnosis of PTSD It also requires the insurer to arrange and pay for a diagnosis by one of their designated psychiatrists, including the travel costs if the claimant has to travel to attend the appointment. Now, it's unclear why the bill contains that limitation when there's a national shortage of psychiatrists in Australian health. The Health Workforce Australia predicts that by 2025, Australia will face a shortage of around 450 psychiatrists. And it's on the list of the 8 specialists that are currently identified as experiencing workforce shortage here, most notably in rural areas. Further, domestic travel in Australia is severely limited due to the pandemic. Vaccine rollout is currently slow, and predictions of future variants, well, that could affect travel as well. Telehealth is one option that's currently in use by some, some psychiatrists arising from the pandemic. However, telehealth has its own problems. It's raised a range of issues like appropriately setting up the digital space and preparing the person for evaluation, adapting therapeutic techniques for video conferencing, managing clinical risks, capturing and recording clinical details, and so on. Now, most psychiatrists are not trained on how to manage these sorts of technological issues. So arguably, this option requires rigorous research before it can be considered for trauma-related compensation claim purposes, which brings us all the way back to face-to-face diagnoses. The lack of available and accessible specialist psychiatrists risks increasing that time delay in obtaining diagnosis and therefore in processing claims, thereby reducing any speeding up of the claims process that might have been intended. The bill's explanatory notes recognizes the need for an experienced clinician to provide a robust, and I'm quoting, diagnosis in accordance with the DSM-5. Well, there is a preference for such clinicians to be trained in psychopathology and experienced in mental health assessments, as is recommended by the Black Dog Institute and quoted in the bill. Registered psychologists, they also fit this criterion. The National Institute of Mental Health recognizes both psychiatrists and psychologists as able to diagnose PTSD, which, by the way, takes quite a long period to diagnose properly. In other jurisdictions like Canada, presumption laws also set out explicit criteria in their statutes for who can diagnose for presumption purposes, with 7 jurisdictions requiring diagnosis by either a specialist registered psychologist or psychiatrist, and in 2 jurisdictions, a specialist registered psychologist or physician. Now, the benefits of expanding the limitation to include other specialist healthcare professionals include fewer delays in the claims process and creating stronger incentive for first responders in need of help to come forward and make a claim for the benefits required to fund appropriate treatment. It also means that those individuals can really specialize in the trauma experienced by first responders. So in conclusion, the future rates of mental health issues arising from survival of major climatic events and the pandemic is as yet unknown. Experts predict that rates of depression and anxiety are likely to intensify in the general population. And if we base that on past evidence, it's safe to assume that the rate of psychological injuries experienced by first responders will again surpass that of the general population. Now, this bill is an important opportunity for improvement, provided the presumption laws is not too restrictive. So thank you, everyone, for listening. That's my contact details there, should you want a copy of any of the reports I've spoken about. Thank you.
Wonderful. Thank you so much, Dr. Crowley-Sayre. It was great hearing your presentation. And for those who are attending, there will be time for Q&A at the end. So feel free to drop questions into the chat or into the Q&A section, and we'll make sure to get to those after all the speakers have presented. So our next speaker today is Sola, who's a commissioner of police for the Nigeria Police Force.
I'll start.
Wonderful. And Sola, I'm going to hand things over to you. Please feel free to share your screen.
Hi, I think I'm still having challenges with sharing the screen. So, but I've sent, so good evening, everyone. I've sent the study report and the presentation to the WOHA session. So good evening, everyone. My name is Efushola Shuemimo. I'm a medical practitioner. I'm a retired commissioner of police, and I'm the focal person for the law enforcement and HIV/AIDS in Nigeria, one of the focal persons. Today, I'm presenting a study that we did on the knowledge, attitudes, and practices on HIV/AIDS in the Nigeria Police Force. This was done using the Police Action Committee on AIDS. So first, I'll introduce our country, Nigeria. Nigeria is in Africa, and it's in the west coast of Africa, the sub-Saharan Africa. It's the largest economy in Africa. Presently, we have over 200 million people projected. We're hoping to do our census this year. The country is said to have the second largest number of people living with HIV/AIDS. And we have a national agency on control of HIV/AIDS as the main organization or body designated to coordinate the control of HIV and AIDS. The Nigeria Police Force is a single organization. I mean, it's centralized, and we have over 300,000 personnel. However, because since 1930, when it was established, it has expanded. And of course, we have more manpower. It has a lot of designations. I don't want to go into the commands, but we have 36 states in Nigeria and the federal capital, and each of these states, you have the presence of the police force. We also do have presence in the United Nations Peacekeeping Corps. So globally and nationally, and even in the local governments, the police are everywhere. The police set up the Police Action Committee on HIV/AIDS in 1992 as an offshoot of the Armed Forces and Police Action Committee on AIDS. This was because at that time, we found out that the uniformed personnel were set aside as people who were most at risk for HIV/AIDS. The Nigeria Police Medical Services has over 150 facilities nationwide. We have tertiary, secondary, and primary care. And we give out all these services at the state commands and the training institutions. The police set up this committee, the Police Action Committee on AIDS, when we were, as I said, termed to be one of the most at-risk populations. And out of all the uniformed personnel, at that time, the police had the highest prevalence. The Federal Ministry of Health in Nigeria conducted a survey, and in 2007, the police were found to have a prevalence of 3.4%. However, it has decreased, but even though it decreased to 2.6 at the last 2.6%, we were still rated as highest in out of the uniformed personnel. So you can understand why we had to set up that body to coordinate the activities. The HIV epidemic picture in Nigeria, we have said, since presently we conducted the largest survey in 2018, and the prevalence came as 1.4% in 2019. The data showed that over 90% of people living with HIV/AIDS in Nigeria were between the ages, were 15 years and above, and over 60% were females. The HIV epidemic picture in the Nigeria Police Force, as I had said before, from the surveys done in 2007, we had the highest prevalence amongst the uniformed personnel of 3.4%. And the last one that focused on the police was 2.6% in 2017. And now we got the prevalence for Nigeria as 1.4%. So the police are still rated as high risk. In that, guys, we decided that we should conduct a study because we know that the Police Action Committee on AIDS had been set up to create awareness, increase the knowledge, and set up ways for prevention by introduction of clinics where personnel were trained on how to use the condom, the proper use of condom. Condoms were distributed, and we also did testing. Most sites had testing at several sites in the hospital, and we were very good at treatment centers. The study showed that the use of condoms amongst police personnel, the study, we had 2,500 questionnaires distributed in 4 states of the Federation. We found out that the use of condoms was 67%. Those who had protected sex the last 12 months was 59%. Those who had sexual intercourse with someone other than their spouse with 41%, and those who could not describe the symptoms of sexually transmitted diseases was 67% for some and 57%. The female respondents who had been treated for sexually transmitted infections was 72%. This study was just to show how, because we found out that their knowledge was quite good. They knew about the HIV/AIDS. They knew that they could go for testing. And one of the reasons why we actually focused so much on the HIV was because we got involved in peacekeeping missions. And for the peacekeeping missions, it was mandatory to have your HIV status. You know, you had to test. So even though it wasn't the criteria, but it was mandatory. So that also increased the awareness of the personnel, just not only in the police, I mean, even in the most uniformed services. So this was one reason why once we found out that we had that high prevalence, we needed to do something to make sure that there was an effect, there was a decline in that. And of course, you know that police officers are one side of the family. We have their wives, their spouses, and we have the children. So it's a formidable population. If you look at 300,000, and if you were to say that even if it was 200,000 had families with one or more spouses, and then with children, we had a population of over 1 million. So, of course, we know that it was a population that had to be considered. The conclusion was that we needed to focus more on how to reduce the burden of HIV infection among police officers in Nigeria with more targeted interventions. Because we also, as you, from the results from the last survey we did, we found out that most of the people who were infected were between the ages of 15 and 49, which is actually the greater proportion of personnel in the police. We also knew that, we also concluded that we had to have provision of adequate HIV prevention messages specific to the Nigeria Police Force. We had started doing some flyers, and we had also introduced having condom dispensers in areas where we felt that were like in the men's room and the officers' mess, so that if they had to, have needed condoms, they were easily accessible, and of course in the clinics and health facilities. We also, we also had a lot of partners who also provided this for us. In all of the clinics, through the Police Action Committee on AIDS, we had the integration of comprehensive HIV services. And then we focused on training of police officers as community facilitators and peer educators. So what we've really decided, what we focused on was how to improve the services, not only to the personnel, but we also tried to get some of them to become change agents, so they could also talk to people about HIV and AIDS. We know, however, that last year was focused so much on COVID, so we didn't do so much work. But thank you so much for this opportunity.
Thank you so much, Sola. I appreciate your presentation. So our final presenter today, and then if we have time for Q&A, we'll get to those, or people can connect directly on the Whova app, is Mario Morales, who will be presenting on needle stick injuries among law enforcement officers in Tijuana, Mexico. So Mario, I will hand things over to you.
Hi everyone, can you see my screen?
Yes,
Cool.
It looks great.
So on behalf of SHIELD project, today I'm presenting needle stick injuries among police officers in Tijuana, Mexico. I'm Mario Morales, second year PhD student in the School of Government and Public Policy at the University of Arizona. As you know, police officers are routinely exposed to needle stick injuries in their interactions with people who inject drugs. Consequently, they are also exposed to hepatitis B, C, and HIV. There are few studies on this topic, and there are even fewer educational interventions to try to prevent the transmission of blood-borne infections due to needle stick injuries among the police. So between 2015 and 2016, SHIELD project trained 1,800 officers in Tijuana on occupational safety, blood-borne infections, Mexican laws on drugs, and harm reduction strategies. Tijuana is the western border city between San Diego, California, and Baja California, Mexico. The prevalence of HIV is 3 times the national average among the whole population. And almost all the people who inject drugs in the red light district of Tijuana has hepatitis C. In 2015, among 1,500 police officers, the prevalence of reporting a needle stick injury in the last 6 months was 1.5, and there was no protocol prior or after experiencing a needle stick injury in the police corporation. This study is the qualitative part of the intervention, and it's focused on police officers' attitudes and behaviors related to needle stick injuries before and after the intervention. Basically, I conducted 20 semi-structured interviews in the first semester of 2016. The inclusion criteria was the following one. Respondents were active duty. All of them completed the SHIELD training and reported experiencing a needle stick injury in the baseline survey. The primary question was the following one. Can you tell me about the last time you were stuck with a needle on duty? And basically, we follow a grounded theory approach where we detected the emergent themes, trends, and frameworks. We found the following. Out of 20 participants, 15 were men, and the age range was 22 to 63 years old. The median age was 38. 14 participants reported ever experiencing a needle stick injury during the interviews, despite the fact that all of them reported this event in the baseline survey. 9 of those who reported needle stick injury were men, and we identified 4 main themes in the interviews. First, prior the training, most participants got needle stick injuries due to body searches. Second, after training, all participants reported safer practices and higher awareness about health risk associated with needle stick injuries. Third, after training, most participants identified the needle stick injury protocol that was developed by the SHIELD intervention. However, 2 of the police officers who tried to follow the protocol found structural barriers. Finally, the participants identified the presence of drug paraphernalia before a judge as a structural barrier to prevent needle stick injuries. I'm going to present some quotes so you can see what is going on in Tijuana. The first theme is Leo's experiences on needle stick injuries before the SHIELD intervention. Quote, he started to struggle with us. He did stick the whole needle in the palm of my hand. The guy kept saying he had AIDS, so I got even more scared. We arrested him and we presented him in front of the judge, but the judge refused to process him because there hadn't been damages done. An ambulance was called and the paramedic kept saying, you know what, there is nothing to do now, instead of supporting me. I told my supervisor about the incident and he said, no, it's not true. We can do something. So I said, well, let me go to the clinic. When I got there, they said, you know what, we don't have anything to test you. A family member who was also a police officer asked the suspect to take a test and they took him to a lab. The person didn't have AIDS, but he did hepatitis C. So I live with the uncertainty that I must be checking to myself every so often. Second theme, Leo's attitudes and behaviors on needle stick injuries after the SHIELD intervention. First quote, every time I search a person, I ask them, do you have anything I could stick myself with? And take all your stuff out first, everything that is in your pockets. When you do the search, you are now more thorough. And now it's always in my mind. And I have seen other colleagues to do it too. Whereas before it was rare for people to do that. Second quote, I didn't know the way to transfer and deposit needles. So it was very useful that I was told, you know what, a hard plastic bottle is the most effective way of delivering needles at a health center so they can get rid of them. I didn't know that. I used to take them and destroy them in the streets. I used to smash it and throw it in a trash can, which they said is also wrong because it will get in the hands of someone who goes through the trash. Third theme, unintended consequences of the intervention. Quote, I let my supervisor knew it, the needle seek injury, and got the corresponding test. And the doctor didn't know how to do it, the test and the interpretation. So he said, you know what, it looks like you tested positive. Well, my world fell apart. So what I did was to head to the clinic. I told the doctor the story and he laughed because he said, if it's like you are telling me, it's negative. I said, what do you mean? I need to know now. The person who took my blood sample said, I will stand in line for you at the lab and give you the result in 2 hours. Just don't tell anyone. And the nurse or doctor came out and said, no, it's negative. So in that moment, I felt more relaxed, but up until now, I am still afraid. Finally, the fourth theme, structural factors outside the scope of shield intervention. Quote, there are some judges who have asked for it, drug paraphernalia. What we do, we put it in the patrol car, which shouldn't happen because we don't have the appropriate methods to handle that stuff, like a pipe or a bulb or aluminum that they use to consume their drugs. When we get there, if the judges ask for it, we show it to them. If they don't ask, we tell them that we have the pipe they have been using. Discussion. On the one hand, officers reported behavioral changes after the intervention, for instance, asking for sharp objects before frisking, ceasing to conduct random body searches altogether, using gloves and syringe containers, and utilizing improved techniques to manage and dispose of syringes. On the other hand, despite the participants correctly identified the needle seek injury protocol that was created after the intervention, the two participants who followed the protocol found that the medical personnel were not able to implement it. So there is still much work to do at the institutional level. I want to thank the Tijuana Police Department, the participants, NIDA, and all my co-authors, Peter Baker, Maria Mittal, Teresita Rocha Jimenez, Erika Clearly, Jaime Arredondo, Javier Cepeda, Stefan Istrati, and Leo Beletsky. There is my contact information in case you need anything else. Thank you.
Wonderful. Thank you so much, Mario. So for those left on today's panel, I just double checked and it looks like the presentations and reports have been uploaded to the document section on Whova. So if you're wanting to learn more about any of that, it is there and easy to access. So before we hop off, does anyone have any, oh, it looks like someone might have a question. Oh, Jennifer.
It's me, Jen.
Hi.
I love these presentations. Thanks so much. And they actually had a lot that connected them as well, even though they were in different jurisdictions and had different foci. But I think one common theme that cut across for me was just the lack of support, not only professional support, but also informal peer-based supports. I mean, there's a cultural piece in here in terms of just changing cultures to promote wellness and to recognize, the mental and behavioral health issues that first responders have to struggle with every day. So I was wondering if maybe starting with Linda, going in the order of the presentations, you could say more about whether this has entered into the discourse yet about how just the role of peers and sort of informal mechanisms for changing cultures, right, in our first responders agencies to support one another going through these behavioral and physical health issues. If there's an emphasis on that, or is it more focused on more formal interventions, in your case, psychiatric interventions?
Thanks, Jennifer. Look, I can say that, okay, so my presentation, I'm focusing on law, right? All those big reports, and I've heard and read many reports internationally, they all sing the same song. They make the same tunes. They gather the same round table of first responders and their leaders, and they have one-on-one interviews, and they gather this data. That's how it's taken so long, or one of the reasons, I suppose, why it's taken so long to capture this information. At the last Law Enforcement Public Health Conference, I gave a presentation on the Australian Federal Police as an example, with the enormously high suicide rate in our most elite police force. We had the most independent, the ANIO, so it's a body that has the greatest power, made a report about the Australian Federal Police based on the management of these. And they're the ones that talked about the culture, the not only between the police against each other for mental health issues, but against women, and it's the usual suspects. And from this conference, year after year, I hear the same thing. Has it changed? Well, I suppose if I didn't keep reading reports about the same thing, I'd be saying, geez, yeah, there's been a lot of change. I think with the federal police, on my topic last year, I know for a fact that they got a new police commissioner, and he made sure that the police had to lock away their guns after their shift. So that's the level of change I personally am aware of. Now, I'm not trying to do a disservice to all the police forces. I heard in Canada and the UK yesterday, when I was listening to recordings, that they've made leaps and bounds in attempting to change the culture. And the little problem I have is I look at my own workplace. I look around it, and I listen to a lot of workplaces, because workplace is my area of interest. And everyone's bringing in online training on, if you look at the news and Google the news in Australia, we're looking at the parliament is a mess with sexual harassment, rapes, and all sorts of disgusting behavior that is going on. And women have had enough. But culture is a really tough thing to change. And yeah, I'm not aware of a hands-on massive change. Now, Canada is a bit of a hero for me because they've had presumptive laws for a long time. One of my questions, though, is, if your presumption laws are working really well and police officers and first responders are coming forward. Now, if you think for a moment, huge deficit, right? A big barrier is the workers' compensation claim process. Traumatized people aren't coming forward to get the help they need. They don't want to tell anybody, and we'll put all these precautions in place. Here's my question. If you had a massive need and you had laws that prevented the need, you changed the laws to make it quicker and easier for them to use it, surely you would expect and want huge amounts of claims coming forward. And we're just not getting that. So politically, it says, oh, don't you worry about having these laws, because, we're not seeing a floodgate of claims. It's okay. The insurers are going to survive. It's okay. But I would love to see a huge jump in the number of claims. That means all those people we read about in the reports are actually getting the help they need. So I don't know if that actually answers the question, but from my perspective, that's the cultural change I'm seeing.
I love that. Thank you. Because as you say, if people aren't using these new legal mechanisms, it speaks to the underlying culture in its current state, right?
I'm not sure if the time is up because it's already time. I don't know.
So you're welcome to share your thoughts if you want to, and people can hop off, unless Jen, someone else needs this virtual room.
We're okay for a few more minutes because this channel isn't being occupied for the next sessions.
Okay.
Okay, well, for Nigeria, it seems as well, not that it seems as if everyone is having the challenges right now, but we haven't really, we've kind of not done too much right now. And we are still having some beliefs that are not just going away. So especially when you look at things like using condoms, having protected sex, there's still a lot of challenges, and it's difficult really to get them to adopt change or adapt to these changes. I know that but I would appreciate if there's any way, if anybody knows, if we could do more surveys, because sometimes it's important to know why they have these beliefs, whether, as we said, it could be cultural, because we are we have a lot of beliefs about a lot of things. And it's something that we need to try to address, because they need to understand that these are, because, like, for example, a lot of people say, oh, HIV/AIDS has been on for a long time. How come they haven't developed a vaccine? So if you have any opportunities for us, we would really appreciate, so that we can partner and collaborate to have more research done in this, guys. Thank you.
I just want to mention that the intervention was a great success in terms of creating consciousness about police officers on occupational safety. They didn't know anything about the risk associated to needle stick injuries prior the intervention, and after the intervention, and they knew what was going on. The thing is that it can also have like unintended consequences, because now police officers are going to be very pissed off if they are stuck with a needle and they can't react against the people who inject drugs due to these reasons, like negatively, I mean. And also there are many structural barriers to try to provide healthcare once a police officer has been stuck with a needle.
Thank you both very much.
Yeah, thank you, everyone. Really appreciated you all making time for today's panel. It was wonderful hearing from you, and I hope you enjoy the rest of the conference.
Thank you very much, Katie.
Bye.
Thank you,
Thank
Katia.
you. Bye-bye, everyone.
And
Thanks
bye,
so much,
everyone.
Katie.
Thank you so much. Thank you. Bye-bye. Bye.